In 1961, the Novolazarevskaya base was a frozen island. A Soviet expedition was cut off from the rest of the world by the Antarctic winter. No planes could land, and no ships could break through the ice. Leonid Rogozov was a young surgeon on that team, but he occupied a precarious position. He was the only doctor on base. If anyone else fell ill, he was the solution. If he fell ill, the base had no medical support. That single point of failure was tested when Rogozov began feeling a sharp, localized pain in his abdomen. The diagnosis was immediate and grim: acute appendicitis. Left alone, an inflamed appendix will rupture. In a remote station with no hospital or advanced recovery tools, that rupture leads to a certain painful death. This wasn't a problem that could be managed or deferred. The geographic isolation and the biological reality created a scenario where every standard solution was physically impossible. When standard protocols vanish, most people fall into a state of paralysis. We're trained to follow a system, and we struggle when that system is suddenly deleted. Rogozov looked for the exits and found none. There were no planes to call for evacuation, and no other medical professionals within thousands of miles. This decision logic forced a choice between inaction and extreme intervention. Waiting for rescue dead ends in a guaranteed fatal outcome. That left only one option. Rogozov would have to perform the surgery on himself, a procedure with no established record of success. He chose to embrace an agonizing, low-probability action because it was the only way to avoid the certainty of failure. Resolving a crisis of this scale requires a complete abandonment of the hope for a painless standard fix. When you lose your specialized infrastructure, you have to repurpose whatever assets are still standing. Rogozov realized he couldn't do this in total isolation. He needed a support team, even if they had zero medical background. He spent his remaining strength training the base's scientists and engineers. He taught them how to hand him specific instruments, how to hold a mirror at the correct angle, and how to keep a makeshift operating room sterile. This effort transformed a group of laypeople into a functioning, if rudimentary, surgical crew. This matrix highlights the heavy cost of delegation. He gained physical support, but introduced a massive infection risk by bringing non-experts into a surgical field. The highest cost was cognitive friction. Rogozov had to micromanage their every move while undergoing severe bodily trauma. Delegating to an untrained team in the middle of a crisis doesn't lighten the leader's load, it actively increases it. The environment was stripped of any modern comfort. He was left with basic metal tools and a bed in a small room on the ice. Choosing the anesthesia was a strategic trade-off. He could only use a local anesthetic to numb the abdominal wall. This kept him awake and conscious enough to guide his own hands, but it meant he would feel the intense, visceral pain of moving his own internal organs. Because he was lying down, he had to use a handheld mirror to navigate. The mirror reversed his vision. Left was right, up was down. This forced his brain to translate movements in real time, making a simple incision incredibly dangerous. This sensory handicap turned a routine 20-minute surgery into nearly 2 hours of slow, careful navigation. To maintain executive control when a system fails, you often have to sacrifice your basic physical comfort and visibility. As the hours passed, Rogozov's vision began to blur. Blood was pooling in the incision, and his hands were shaking from the sheer physical strain. His body began to slip into shock, an involuntary shutdown. To stay awake, he took short, frequent breaks to breathe and regain focus. Taking breaks saved him from fainting, but it prolonged the time his body was open and increased the total amount of blood he lost. Eventually, he located the appendix by touch, removed it, and stitched himself back together. Rogozov survived because he prioritized measured, stubborn endurance through peak agony over technical speed. The immediate result was survival. 2 weeks later, Rogozov was back at his post, and his team had avoided a total medical catastrophe. Plotting the difficulty of these tasks versus their impact on survival reveals where value was created. Mirror navigation and local anesthesia fall into the maximum difficulty, maximum impact quadrant. Even using an unqualified team proved essential to the final outcome. Solving a critical failure is rarely an efficient process. It usually looks like a grueling endurance test defined by terrible trade-offs. For anyone managing complex systems or projects, the story of the Novolazarevskaya base provides a blueprint for when your own redundancies fail. There are 2 ways to operate: as a system-dependent operator, optimized for efficiency, or as an executor who can survive when that efficiency is stripped away. If your role is to manage risk, this story shows the absolute limit of having no backup. To avoid this level of friction, you must engineer single points of failure out of your systems before the environment changes. But if you are the one stuck when the system breaks, you have to be willing to abandon efficiency, micromanage the assets you have, and absorb the operational pain. Surviving a zero-option scenario requires a calculated, willful acceptance of severe trade-offs to prevent a total collapse.